Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper, and this is our Pulse Summer Series, where we are revisiting some of our most timely and enduring conversations from the Pulse Pod archive. And this episode is a special one. Back in late 2024, George and I sat down with Dr. Karen DeSalvo, Chief Health Officer at Google, former US National Coordinator for Health IT, public health leader, clinician, and one of the most thoughtful voices globally on how technology, policy, and equity intersect in healthcare. We covered a lot of ground in this conversation, from Karen's journey as a physician and public health leader and how she landed at Google in the first place, to why patient access to their own health information matters deeply. From AI's role in drug discovery and clinical practice to how generative AI could transform public health, prevention, and global health equity at scale. And what makes this interview worth revisiting now is just how prescient it was. Karen is incredibly impressive. She talks about AI not just as an efficiency tool, but as something potentially as transformative as penicillin, reshaping science, care delivery, and the experience of both patients and clinicians. She also speaks really candidly about trust, misinformation, equity by design, and the responsibility that comes with operating health technologies at a planetary scale. So if you're thinking about where digital health, AI, and healthcare systems are heading and how we bring humanity, joy, and fairness along with us, this conversation has a lot to say. So whether you heard it the first time or you're listening for the first time now, we're delighted to bring you this episode of Pulse Summer with Dr. Karen DeSalvo. Today, we are thrilled to welcome Dr. Karen DeSalvo, a true international powerhouse in the world of health, innovation and technology. As the Chief Health Officer at Google, Dr. DeSalvo is at the forefront of integrating medicine, public health and cutting-edge technology. Karen has spent her entire career improving health outcomes, championing equitable healthcare and addressing all the determinants of health. From her time as Health Commissioner in post-Katrina New Orleans to her leadership in the Obama administration, she's made quite an immeasurable impact. Now at Google, Karen leads a global team that's shaping the future of healthcare in new and innovative ways. So pleased to have you. Welcome to the PulsePod studio, Karen.
Oh, Louise, thank you for having me. I'm really excited to be here. George, it's great to see you too.
Great to have you on board.
Now, Karen, we always love, before we get into the nitty-gritty of digital health topics, is to talk a bit about your personal journey. So I understand you're a board-certified internist. In addition to being a medical doctor, you also have a Master's of Public Health and a Master's in Clinical Epidemiology. So on behalf of all the medical doctors that listen to the show, they definitely are going to want me to ask you, so how does a doctor go from treating patients to having the top health IT job during President Obama's term to leading health innovation for one of the biggest tech companies on the planet?
Well, I ask myself that a lot. So, it's been a wonderful journey, and I loved practicing medicine. But one of the things that I got involved in very early in my career was quality improvement. And that was back in the late 90s at Charity Hospital in New Orleans. And we were using paper records, and we had a public hospital that had a scheduling system that was by paper and sort of catch as you can. If people could get an appointment, great, they got in. They didn't have health insurance, so they didn't have a lot of other options. So these two kind of very broken systems of one, when the person was in your clinic, you didn't have their medical record because for a variety of reasons, which I came to understand, the paper records didn't get to clinic. And also we didn't have an automated scheduling system. We were still doing something by hand. And I learned a couple of things at the same time, partially because I was chairing the medical records committee at the hospital. And then also I was running the clinic. And I learned that we had purchased an electronic scheduling system. We just never turned it on. And that system also had a way to connect with the medical records team to at least create an auto-generated list of here's the patients we expect to come tomorrow. And so that if the human was out, there was still going to be a computer-generated list going downstairs to the medical records department. And by flipping on those two things, lots of change management involved. I don't want to make it sound simple. We were able to go from a time when we only had about 15% of the medical record when people came to clinic up to being more like 85%, closer to 90. And we were able to get the next available time in clinic from a year down to 2 weeks. So it was the first time for me that I went, oh, technology can augment what humans do, sometimes do it better. And even sometimes when you pay for the technology, you're not using it properly to do the things that you set out for it to do. And I remember very vividly how I got excited about how technology could improve access to care and the experience of care. And sort of fast forward to Katrina, I was teaching and doing research and in academic medicine. And when the storm knocked out our healthcare system in New Orleans, it also flooded our health records. And so as we started to rebuild the community from the ground up, we took the opportunity because of the timing around 2005, 2006, to take advantage of the funding that had been afforded by the US Congress as part of the HITECH Act to create funding for implementing electronic health records, connecting those with the information highway, the health information exchanges, and then studying improvements in population health through the Beacon program. Those are the three big grants that they had. And Louisiana applied for all three, was successful for all three. And I was very involved either as the PI or on the steering committee or implementing, running the quality forum. There are a lot of ways that I was engaged with the Office of National Coordinator in that work in Louisiana. Got to know a bunch of folks in the administration, and that's how I got put up for the job, which I eventually took as the National Coordinator for Health IT, because the then secretary said, what I really need is someone who is not a technologist, but knows how to apply technology to improving people's health and population health. Then when the administration ended, I was a presidential appointee, so I was waved goodbye and had to leave the administration. But over the course of my time in federal service, I had been working on a mix of public health, medicine, and technology in a variety of roles I had in the Obama administration. And I wanted to find a way to merge those things, to bridge those worlds, to bring the best of all to improving health outcomes for people. And after some work I did for a couple of years following leaving the administration, Google called, basically. And because some work I had been doing, advising some organizations, speaking, et cetera, I guess I came to their attention. And they said, we want somebody who knows medicine, public health, and technology, because we want to improve health of people around the world. Are you interested in putting your name in the hat? And I said, heck yeah, and applied, and I successfully became the inaugural chief health officer at Google. So it was really just a journey of maybe I've been picking up things along the way, but it was all in service to, how do we make the experience better for the people who are being served, the patients, or for the people who are serving, and then thinking about how that also informs the way we improve the population's health in addition to what we can do for individuals. And technology and data is so important for that work. You can't really do meaningful work, especially if you want to do continuous quality improvement, unless you have that kind of information to guide what you're doing.
Absolutely.
Excellent. It's interesting, most clinicians don't graduate thinking, I'm going to go into digital health. We all tend to fall into it. I was fortunate enough not to have to require a natural disaster to trigger it. So that's one great thing. But back in the days when these discussions have been going on for a long time, and personal health records have been a discussion topic from the early 2000s. I know you're a big proponent of the patients having access to their records. How did that start for you?
It actually started for me when I was a medical student. I went to Tulane in New Orleans, and I had a rotation in psychiatry. And there's a physician there, Dr. Don Gallant, who was a psychiatrist who worked in a clinic that served uninsured individuals who were getting substance use disorder treatment. And he modeled something for me that was, he would write the patient encounter notes. These are pretty high risk, low resource individuals who were in a free clinic, basically, and he would write the note, and then he would say, now I'm going to read you what I wrote after the end of the visit. So he would then read the note, because he didn't want to make assumptions about literacy or anything else, read them what he had written, big transparency moment. And the way that they received that, the dignity that gave them, and the way that their body posture would just change about, oh, I'm in this with him. It's not him against me, or there's secrets. I never went back. And I think as a physician, even though we were in a paper records time, it was so clear to me that if I wanted to be in it with my patients and have them in it with me, we needed to have information sharing. And they needed to know a lot about their health. And so, every time I had an opportunity, whether it was reading them the note, whether it was back in the day printing and handing them their test results, I've always been an advocate for that kind of an open notes, if you will, sort of model of care. And the PHR is just an extension of that. It's a way that people can begin to not only know about that episode, but about their health all across their lifespan. And I think it's turning out to be life's work, honestly. I think all of us have been trying to find a way that it's palatable and happen in a way that meets the privacy and data volume expectations. But I think we get closer every year. But yeah, it was really grounded in watching how people responded so positively to being included in what was being documented about their health.
And it is interesting how one teacher can really drive a whole mindset change. I reflect back on my training. I had a Professor David Tiller who taught us about taking medical histories, the importance of that, and that becomes ingrained in you. So that's really important to pass that on to the next generation of medical students going forward.
Sure is.
Absolutely. Well, apparently I've learned, Karen, we can't do a podcast without talking about AI. So I have a couple of AI questions for you. Now, you've been quoted saying that AI could change health on a planetary scale in the same way the discovery of penicillin almost 100 years ago did to revolutionize healthcare. And we're all very grateful for that. Why do you believe this to be the case for AI?
And I tell you why I think of it as that transformative. Yes, technology can automate existing processes, improve efficiencies. There are many ways that we've already seen and we're going to see technology like AI improve the efficiency and effectiveness of experience. But in the way that penicillin transformed the way we cared for people with infection, that's how AI is going to transform the way that we practice medicine or do science. And it used to be sort of drain the abscess, watch and wait, all sorts of other things that we did in medicine that weren't really so evidence-based. But then when we had a therapeutic we could give people, it not only saved lives, it shortened time in hospital, saved limbs. I mean, just had this completely different way that we thought about delivering a treatment. And it came with it then a whole set of other kinds of considerations about what was sickness and what was likely to cause mortality. It changed our conception about who we could help and save, quite frankly. And I think AI is quite similarly poised to do that if we are strategic and don't only automate existing processes, but think about how something like AI can become a helpmeet for the every person to have that coach or physician friend that they can have as a first call. But then also for clinicians to have the opportunity to always be their best selves, because they might have an AI version of themselves practicing medicine when they were at the top of their game and they're not post-call and all the things, but also to be able to call on AI agents that can augment their practice. And there are times in my practice where I needed a great social worker or I needed a cardiology specialist. And for some people, like even in my practice, because I was in a public hospital that was very under-resourced, I didn't have that at my disposal. And it's very true for many providers all around the world today, where either there's no access to a provider for some people on the planet, but also sometimes people are just like a community health volunteer going it on their own. So we start to think about how AI becomes a team member, virtual one that fills some of these really important capacity and capability gaps, and also augment the care that gets delivered. That's sort of one bucket, and we could explore that further. I think what we're seeing most acutely, though, Louise, is how AlphaFold, as a large language model, not even, true Gen AI, but AlphaFold has already transformed the way science is understanding drug development, acting on drug development, and protein folding, ligand folding. It's changed the way that PhDs approach their science. It's changing the way that we think about developing more personalized drugs, including for some orphan diseases. So I think at the leading edge of this, honestly, is drug discovery and therapeutics because of technology like AlphaFold and the things that'll go around it. But it's also true that we're going to be able to not only address morbidity and mortality with that, but in ways that we're able to augment the care teams and bring the best science right to the bedside.
Absolutely. And the pace of change, I mean, you're at the forefront of it. The tech we have today, it's going to be the worst it ever is. Like, it's only going to get better. Like Nobel Prize winning technology, it's really impressive stuff, and it'll make such a big difference to so many people's lives.
I'm glad you said that the technology we have today will be the worst it ever is, because it is in many ways true. And I think for the listeners to just try to articulate this point about how quickly the science and AI is moving, whether that's the science around improving factuality and groundedness, or the science around multimodal technology, the models that can see and hear and bring all that data together to do a better assessment of the 360 of a person's health. And also the way the models are getting improvement in interaction so that they're more accessible to people. So not just text, but also voice audio to audio, which expands the capabilities and the reach of models, including for populations where communication isn't always grounded in being able to write or type, or maybe your second language is English and you're a great speaker at it, but you may not be able to write or type. We see this, for example, in India, where we have a big presence and people very fluent in English, but it's not something they've learned to read and write in that sense. But being able to speak to a model really opens up opportunities for it to be able to be supported in the work they do or in the care that they're delivering. So I just want to make sure people are tracking on. It's not just the applications, but actually behind the scenes, the science is super exciting and evolving really quickly.
So it's great we're using the analogy of penicillin, because down here in Australia, we're very proud of the Australian Howard Florey's role in development of penicillin. But when we look at other aspects of healthcare, I know you've got a particular expertise in public health, we find that how we use technology in public health has been a slowly evolving pace. You recently co-authored a paper looking at the practical applications of AI in public health. But how do you think generative AI can help us transform the way we deliver public health? Because, I don't know, in Australia, we still struggle with the public health models of care.
Well, I worked in public health at the local and the national level, and now I've had a lot more exposure to global public health. And unfortunately, a very similar theme rings through, which is they tend to be pretty underfunded and under-resourced. And this is one of the incredible opportunities of generative AI to be able to help with some of those capacity gaps. How do I mean that? As we wrote about in this paper that we published in Health Affairs, there are even some very straightforward ways that the models are good at today. So, for example, communications. I'm taking a topic such as boil water advisory for a community and translating that into multiple languages necessary to reach the population, or modifying that to reach a certain literacy levels in the population. Is something real time public health officers are doing all the time. You're trying to create communication tools, not only for crisis, but for every day. So enhancing that communication function of public health and accelerating it. Also, not just helping to rewrite it, but helping to do the search of the literature of what is the best evidence that's out there and how can that be brought into the communication that we're writing. So, for example, AI overviews, which is now on our search surface, has a citation. So if you search on a topic, it tells you what's the source of that. And so for public health, very important to be highly factual and know that this came from the WHO on this website of the WHO, so you can actually find it and know it's credible. There's another tool that we have that wasn't even out when I co-authored that paper with others, called Notebook LM, which if I were in the seat in public health, I would be using for everything. Notebook LM is sort of like the best research assistant that you could ever envision on the planet. You can dump all of your documents in there, all the information you have about, say, H5N1 that you're keeping track of, the websites from the various public health agencies, and query that to find, can you direct me to all the cases that have been linked to dairy farms? Can you show me all the human cases? And it will cite those and assemble it. It also happens to do a podcast, which is quite entertaining, sometimes extremely helpful. It has multiple utilities. And so for that kind of on the moment function of finding the best evidence and communicating that to the public, I think it's a no brainer, because all those are free tools and they should be using it now. The surveillance functions, very similarly, I think are going to be incredible use cases. There will need to be a lot of intense human in the loop for that work, and I think the model's ability to do math and really get very well grounded and have the appropriate factuality temperature for that will mean it's going to be a bit more of a journey. But they're so good at analyzing big volumes of data and finding signal in that noise. I think those are two really good examples, one very proximate and one that's more emerging of how public health can use the data. But as we sort of talk about in the paper, things like filling out forms and reports are also examples of how it will be useful. And I think public health sometimes tends to be a little reticent about using new technology, which is great. I mean, it's a very rigorous evidence-based field. On the other hand, if you don't start getting used to it now, it'll be too long between the knowing and the using to be able to help. And I can't help but thinking of examples like the Text for Baby apps that we had texting for so long, we weren't using it yet in public health. We have apps like that for public health. I think that the delay is longer than it needs to be. And so I'm an encourager of public health around the world, understanding how to use this technology. Maybe just a quick final point, George, which is it's one of the reasons we've been working so closely with the World Health Organization so that we can understand as a company, what are the ways that that public health around the world might need to use this technology? Is it fit for purpose? What are the ways that might be more useful? Like, is it better to have a GOFM model that looks at the nearest site for obstetrics care, which is something that we've worked on? What are the use cases basically that will be the most useful to the most people in the nearest amount of time? And how can we work with them to make sure that they're helping build confidence with public health agencies around the world? Because just because Google says it's good, it doesn't mean that people are going to use it. It's definitely better if someone who really understands your deep daily work, like the WHO and some of their field organizations, can also help understand that it's useful and safe.
Thanks. That's fascinating. And again, it builds on that public health principles of delivering care at a broader community rather than at an individual level. Many clinicians are trained on a one-on-one, but understanding public health, and these tools will enable us to do that at that scale that's required to make it effective.
Yes, and that's a good segue when we talk about scale and numbers. So, Karen, the data I have, you have to forgive me, it's 5 years old. But anyway, it's to process a point. So I had a look at the amount of searches that Google processes every day. I know Google does a lot more things than just the search engine, but, that was the beginning. And what I found is that there's 8.5 billion searches every day, but that 1 billion of those are health related. So I timed it roughly. And by the time I finished asking you this question, over 50,000 health related questions would have been sent to the Google search engine from people all across the planet. Now, this is an incredibly valuable service, but one of the downsides of all of this information is the ability of misinformation to thrive. And it's certainly what clinicians worry about. They're concerned about misinformation. So how's Google addressing these challenges, especially in building those transparent, bias-free AI models for these public health applications? Because, trust is just so important, and also equity in access to information, which I know that you and Google are real proponents of.
We do get several 100 million health queries a day. And one of the things I learned after I came here was that people also ask health queries, health questions in new ways every day, things that we've never seen before. So it's a constantly evolving expectation the user need on the search surface. Let me say a couple of big ways that we think about that information platform. One is in moments of crisis or need on their health journey, people don't usually go to, say, the ministry website as the first place. They tend to go to search. And then we have an interest in helping them find the best information for their health query. And usually that's directing them to the government ministry or to some other credible authority so they can find additional information. We'd done a little bit of that work prior to the pandemic, but it was really starting in 2020 that working with the World Health Organization and local governments, as well as increasingly with some authoritative groups like, say, Apollo Hospitals in India or the Mayo Clinic, we began to get better at being able to do some things that we call like content forward. How do we, following all the rules that we have to follow to give people a search result, also kind of put a pamphlet up? Essentially is what it is, like what we call a knowledge panel. And here's the information on COVID or diabetes or high blood pressure. So it's easy for you to find. And here's the sourcing link to the authority that's going to tell you more about it. We wouldn't write those knowledge panels. We actually do that with authoritative organizations, not because Google said it's good, but because an authority does. We've expanded that work, especially on surfaces like YouTube, where we get a couple 100 billion queries for health a year. And the way that we've worked on that for the YouTube service, where we have more latitude to work with content creators, is to help them know, oh, look, we're getting a lot of questions about, say, nutrition. Can you, organization, ministry, or National Academy of Medicine, build out some content that will be responsive to what people are asking? Again, Google's not making the content, but we work with designated authoritative organizations that are designated as such because we asked first the National Academy of Medicine in the US, and then the World Health Organization, and then a set of governments to tell us what's authoritative. What is the kind of groups that we should look to give the best information, high quality information to people? So sometimes it's an accrediting organization. Sometimes it's the National Health System. Sometimes it's a licensed clinician, depending upon the geo where they are. So that's sort of two big ways that we've thought about, again, helping people find high quality information more easily. And then secondly, helping to create it on YouTube, like working with content partners. We would always, especially on search, show pretty much everything except stuff that's incredibly harmful, because that's what the law tells us to do, Section 230. Place where we don't always want to show what people are asking for is what we would call interrupting intent. So if somebody searches on a query that might indicate they're trying to harm themselves, like maybe they're suicidal, we wouldn't want to show them how to do that. We want to instead pop up a one box. So say, oh, you might want to call this hotline number. And if you're feeling depressed or suicidal, this is a place where you can reach out for help. There's chatbot versions, and each country has its own. We wouldn't want to put forward harmful information, and we have some life and death situations where that's the kind of work we do. And by the way, we use AI behind all of that to try to help sort out what it is that people are asking for. Look, on the misinformation side, I think a couple of call outs there. One is Gen AI is going to make it much harder for all of us to address misinformation. It's faster to generate. It looks more sophisticated. And there are things that we've been working on with others in the ecosystem, we, the company, with others to do things like watermarking videos. And we would like to see more of that kind of oversight and regulation with government so that people can more clearly know what's clear information. We also will look for misinformation like this is telling people that it's safe to make baby formula in a certain way, when indeed, if they followed that recipe, there would be toxins in it that were clearly outlined in the literature that would be harmful to a baby. That is a real example of something we've had to deal with. So we would look at the literature. I actually have clinicians and a librarian on staff that are doing this work, and we use AI to help grab literature. Oh, this is clearly harmful. It's been proven in the literature. So we would want to pull that down as content, especially on YouTube where the videos pop up. So we think about it on two ends then, like true public health messaging, raise high quality information and remove harmful misinformation, especially when it's on YouTube where we have much more latitude to do that than we do on some other surfaces. But Louise, it is an ongoing issue and bit of work, a big bunch of work for us around the world. And I think a message to all the listeners is if they find things that look like, oh, I don't think this would be the right search result or video result, there's usually a bug link on somewhere, and they should report that to Google because we want to fix things if they're not working right. So we welcome that input very much.
No, that's amazing. And I couldn't imagine the amount of people hours that are put behind all of this. It's really complicated. And Australia got it in recent months that, now when you do a search for anything, you do get the Gen AI automated response first. I'm sure you're finding data that's helping people as well, because, usually it gives them the information which is accurate and links to, like you said, sites, actual resources that then you can go and check out this website or look at this video.
Yeah, I'm really glad you asked about that, because what we're seeing a little bit from the way people are interacting with the site, all anonymous, I don't know who it is, but what we see is that people like having a few paragraphs about the thing they're searching on with multiple sources that have written. And that's what AI overviews will bring them. And where health is so complicated, it is very often more helpful than just a set of links or even a knowledge panel, which in times like COVID or for H5N1 can get out of date pretty fast. So it helps keep us a little timely also.
So going back to the turn of the century when electronic medical records were the real buzz, and that's how many of us got engaged with digital health, one of the major complaints physicians, nurses, a lot of care workers had was how the tools didn't align with their needs. Their workflows were disrupted. Their tools were designed for capturing data for non-clinical purposes. What are you guys doing to make sure that clinicians collaborate with your design team so that the tools you design are designed to facilitate their workflow, meet their needs?
I have a few reflections about the electronic health record era and especially the early days. And you sort of captured the sentiment. And I think part of the reason for that was there wasn't user-centered design. And also when we were entering data into the electronic health record, it was kind of going into our database, in your clinic's database, but there was nothing coming back. So the ROI was very intangible and more tangible maybe to the billing department than to the actual clinicians, which I think makes the era that we're in now of generative AI so different. It's one of the reasons probably there's been so much uptake of these new models, whether it's for helping you plan a birthday party or helping you review the literature. They are more capable of returning that investment. So as you put in the time and the work, it's easier to get some help. Essentially, it augments what you do. It's not a drain on what you're doing. In between all of that, I think is just what are the tools that we can build that support clinical practice, that support the clinical encounter, that support things like a tumor board. And I'll say that we at Google very intentionally have doctors, nurses, clinical psychologists, pharmacists who are part of the team across the company that are at the elbow of the engineers and the designers so that they are a part of not only building the tooling because it'll make a difference in people's health, but also what's the workflow look like. And we have some really good examples of how we've done that work very deeply when we're building software as a medical device, like for mammo readings. Get into the clinical environment, go into the reading room with the radiologist to understand how the tooling might be more useful. Well, sort of fast forward to today, I think it's not only because of pace, but because the scale of what clinicians want to do around the world, we're very much count on our partners to augment that. So we'll call it a wet lab. Like we'll build a thing and we say, this looks like it's going to be really helpful to do. I'm going to use tumor board as the example. If you wanted to review the literature and sort of understand if it was going to match up, if you find any trials that'll match with supporting cancer care delivery. But then we need a partner who really runs hospitals and actually has real tumor boards. And so in that case, for example, we're working with Princess Maxima in the Netherlands, and the clinicians there have been using Gemini to review the literature, to find clinical trials that might be appropriate to match up with the child that they're going to present at tumor board, and then use that to accelerate the discussion, shorten the timeline to finding relevant clinical trials. They've seen things in those conversations where a clinician will say, I've tried that therapy for children with this kind of cancer before, but it didn't work. And one of the things, for example, they've realized is that Gemini can find all the published literature, but people don't often publish negative studies. So I just think it's a great example of how the humans who know the real world and what they've tried and what didn't work, but it may not show up in the literature, and Gemini is only going to know what it sees in the literature. But together, that helps to make their work better. And so that's an example of how we really are counting on our partners to say, yeah, it works in this way. And this is how, with human in the loop, those things are improved. I have lots of examples from across the planet, but I think as we move into this new era of how we're going to use technology in practice, we're going to less and less be staring at a computer. We're not going to type at a computer. It's just like, it's going to be talking to us. It's going to be interacting, but hopefully it's going to reduce cognitive load and make that clinical experience feel much more natural and bring back a lot of humanity, but also make it happen in a way that is more bringing better evidence right to the bedside and then helping the patient kind of walk away with that knowledge also. That's another part of the work that I get excited about seeing. So yeah, EHR, thank you. Great. Build a foundation. I'm on to the next thing, which builds upon that. But I think it's going to feel, and it already does, so much more helpful to clinicians than the EHRs did.
Excellent. I'm a big Star Trek fan, so the emergency medical hologram on Voyager, I actually asked Gemini the question, how does it compare with generative AI? And there seems to be a lot of things that in common. So maybe that Star Trek is really what's going to drive our innovation.
And you might have seen that we just recently announced a next iteration of a model we call Astra, which can see and hear. And we don't have medical use cases for it. There are other use cases that we've talked about, like for gaming. But you can also, start to use your brain to imagine what's that like when the model actually is contextualizing the clinical experience with you as the clinician or as the patient. If you're looking together at the film, at the X-ray, Astra's also seeing it and might be able to walk away with the patient as their advocate and remember some of the things that the doctor said. That's not here today, but you can envision those are the kinds of exciting things that I hope we start to manifest. It becomes an advocate. It becomes a part of that health team that not only has the memory and you can chatbot with, if you will, but it is contextualizing.
It's so good. And we've talked a lot on the pod already about the growth in AI scribes and medical scribes, and the idea that as a tool, and it's a very basic tool in comparison to the Star Trek stuff that we will soon be seeing, but it enables the ability, if you want, to create a patient version of the results. It's still got all the accurate information, but maybe uses less Latin jargon that, means something to doctors, but not necessarily to patients. So yeah, we're looking forward to that. On the patient side of things, Karen, and obviously you've said that this has been something that's been with you pretty much since the early days of your medical training. How do you see the future of patient engagement with digital tools enabling that engagement in their own health and health status?
I think we've talked about this before, actually. I think that technology and what comes with it stands to really bring a lot more power to patients, which I'm a big fan of, because knowledge is power. And most of us don't know a lot about our own health. Most of us forget what we're told in the doctor's office or by the home health nurse or the pharmacist. So having that extra advocate brain knowledge with you as your health agent across your journey is going to hopefully not only make people know more, feel more agency, but also just honestly have more power in their own health journey. And I think it will make patients, in some cases, be more citizen scientists. We've already seen a few examples of that where people, because of the Gen AI, are able to get pretty smart about their own conditions and bring new knowledge to their caregivers, which can be uncomfortable sometimes for a clinician. On the other hand, it's really important that we as doctors keep our hearts and minds open to new knowledge. And it may be that Gen AI is going to help find a clinical trial that we didn't know about or that's ongoing somewhere. Those are examples of where I think that there's some good potential to really bolster the patient's role in their interaction. I do think also Gen AI is going to, at least my hope is, it's going to help people from becoming patients. And the really significant way that we think we can help the most people most is through prevention. And for a lot of us, that's just, I need to get my mammogram, but I can't figure out when to schedule it. And I can't remember the phone number to call or whatever. We're all going to have our own chief of staff / agent that's going to be able to navigate and manage that stuff for us very seamlessly. And we won't even have to push it because as they get more autonomous, if we allow that, they're going to do it for us. And hey, your mammogram's next week and I've arranged the car and all the things and ordered your old records to be there for the radiologist when you arrive. And it's on your calendar and like all those things, all those little steps, those tasks that we have to take in our health. And so much of prevention is just about that, just the burden of having to make it all happen. So as a primary care and public health person, I get very excited about thinking of all the ways that that's just going to help with screenings and prevention, but also just helping us all do the right thing, make that the easy thing, take the stairs, remember our medication, choose the apple instead of the cookie. I don't know if that'll ever happen.
That's it. Maybe the science will need to change the texture of the apples, so still healthy. Fan of apples and cookies on the pod, so in moderation.
But that does highlight a challenge we do have because we often talk about our healthcare system being a sick care system, a reactive system, not being a preventative care system, and how we build prevention into our daily activities includes a whole bunch of things around literacy and health literacy and all those sort of things. So you touched on a few things there, but I mean, obviously this is a major focus coming from your public health and primary care background. What other tools do you see coming into place through Google or through your multiple partners take us away from this reactive care model to a predictive, preventative care model where we're avoiding sickness and going forward? I mean, there's a lot of discussion now around longevity and how we can, almost avoid death. What are your thoughts about how tools can take a role in that space?
Well, the little thread that you said of literacy, and I did want to make sure before I get into prevention again that I underscore how important it is that as we're deploying these tools, building them and deploying them, we do it with equity by design. And for us, it's a basic tenet. It's one of the teams that I built when I first got to Google was a health equity team. We have inclusion teams that think about product. I knew we needed specialized health equity talent. And they have a big charge in front of them because equity isn't just about, for example, the way we think of it in the US, black-white differences. There's so many axes upon which we have to consider health equity and disparities and inclusion in Australia. You guys know this well and honor it and respect it. I think the work of thinking about prevention is important tied to that, because very often it's lower resource communities or communities that maybe have linguistic barriers or transportation barriers, have other reasons that it's harder for them to get in, not only for care if they already have chronic disease or have a significant condition, but just for prevention. And that's just true all over the world, whether you live in rural Indonesia or if you live in New York City. So the technology then built with equity by design, thinking about what are the ways people will interact with, receive that technology? What are the ways that we want to, as a company, make it so that, for example, a model can work on device, offline, so that people don't have to be connected to a data center or even to a data plan in order to do some of the self-care work or to receive some of the care work that we do. So as we go along this journey, you'll see that that continues to be important. An example of how we're doing this today that's less Gen AI oriented, but more just basic AI and technology, is an effort called Open Health Stack, where we've been working with the World Health Organization and local community organizations like Jacaranda Health in Kenya, where often it's a community health volunteer or some worker on the front lines that needs help with upskilling, needs access to evidence-based guidelines, sometimes in the moment, whether it's for maternal care or for childhood diarrhea. And WHO might have that data somewhere, but you're not always in a place where you're going to get it. So Open Health Stack aims to work with local organizations so they can build an app easily on the phone that will connect with the right ministry or the WHO guidelines and work offline for documentation for the community health workers so they can document the care visit without needing to be connected to a data plan in the moment, and then they can upload it when they get back. We've got more than 10 million people around the world who are already receiving services because of that kind of technology. And it's just the beginning, because there's 3 billion Android phones on the planet. So the more organizations use it and start to especially think about that as a added tool in the field. You don't need a computer and you don't need like all the bells and whistles. Sometimes it's just something kind of straightforward like that. So that kind of idea of understanding what are the needs for low resource communities, no matter where they are on the planet, what are all the other kinds of ways we want to think about inclusion, will be important as we're working to deploy Gen AI, including the ways that we think about training and building the models. And we've published on some of those areas, George, and there may be some more information people could find on our website, health.google, about ways that we've thought about equity and things like skin conditions. And it's like we've talked about in other ways, as the Gen AI models get more sophisticated, it's the step change in the kind of work we need to do, because like when the model starts to see you and talk to you, it raises, oh, should we be checking the models for things like implicit bias? It's always on our mind. And I'm actually honestly really proud with how the teams have thought about it. And we're starting to see some really nice examples in the field one of which I mentioned, where we're thinking about equity by design and as we deploy the model or the technology in the field.
Thanks. I think it's very important because, like I said, when we talk about prevention, we tend to sort of sometimes think about those who have the resources and have the capacity to do preventative health. And then you have communities, as you noted, that just don't have the resources available to them. That's really important.
And speaking of those communities, a topic you sort of touched on it in your answer before, but in preparation for this interview, I had a look at a report that you co-authored about the United Nations Sustainable Development Goals, and we will put a link to it and to the other papers we've mentioned in the show notes. But according to that report, it's not good news. So 80% of the Sustainable Development Targets have deviated, stalled, or regressed. Only 15% are on track. So what are your thoughts? What do you see happening that are contributing to improving access to healthcare in these underserved regions? Because obviously, and you've mentioned, the importance of equity, but I guess in these underserved regions, they have even more challenges against them.
The Sustainable Development Goals are such an important way that globally, all of us can see how we're moving forward in population health. And, the definition of public health is what we do together as a society to create the conditions in which everyone can be healthy. And I think, as people would see in the report, it's an example of how Google thinks about how it can lean in to health. We have an all-of-company approach. We build health use cases into our products. We have research teams that are thinking not only about how it's going to support and improve things like AI overviews, but how we're going to work with external partners to make data and information available so that they can know how with the progress so that they can begin to do some anonymous mapping of where access points are in the community. And an example of ways that we've worked, like the UN in this, was with data commons, where we used some of our AI technology to help scrape publicly available databases and use that to accelerate and improve the way the UN can follow the SDGs. We would also, and we do, work with the World Health Organization on information amplification, information as a determinant of health, on some of the tools I mentioned, like Open Health Stack, and also on how to do upskilling of AI in local health organizations and in local communities. Beyond that, in the product space, we have ways that we're even think about maps, making data available, anonymized data available, to do something I mentioned, like we called GeoFM as the model. And it's a way that communities can track access to sometimes the social drivers of health, like food access, but also use it to understand transportation access to things like sites of obstetric care. So we would step back and say, SDGs aren't going right. We have a role to play with the broader community. We'll work with the big global organizations in the space where we can, helping to provide data, helping to provide tools and technology, and then just also working to advance communication education. And there's a fourth kind of big stream, which is, how can we help with community resourcing? That's very often .org, which is our philanthropy that works with local organizations, NGOs, and communities to try to, again, build durable skills and tools and technology that's going to help them to advance the broad goals. But it is worrisome that we, as a world, we aren't making as much progress as we need to. And by the way, I mentioned a couple of times the social drivers of health. Even though we think about, for medical at Google, we talk about our 4 M's: metabolic disease, malignancy, maternal health, and mental health as the condition areas of priority. They're reflected in the SDGs. We believe in the WHO definition that it's about physical, mental, and social well-being. And so what we can, for example, with maps, help contextualize people's health, air quality, et cetera, exposure. So ways that we can also step out of that clinical environment, but think more broadly of how can we help inform what's happening in people's health in that broader definition that matters to public health around the world. We want to contribute.
We have a lot of listeners, Pulse Potties. It's a podcast and it's called Pulse, so they're Pulse Potties. It's funny, actually, I see people in real life and they refer to themselves as Pulse Potties and want to know where they can get merchandise. So I'll have to think about that for 2025. But anyway, so there's a lot of them are actually in the startup ecosystem and that innovation economy. And I know that Google offer lots of programs for startups. So things like the Growth Academy, and you've already mentioned Open Health Stack. So what should startup listeners know about what they should check out that Google can offer them?
I'm going to provide a link that you can drop in the notes that is sort of assembly of all the ways that startups can get engaged with Google. We know sometimes it is hard to find the right door. And like many places, we have multiple doors. We in particular have groups like Google for Startups, we have Google for Developers, and all those have a subset, which is in health. We have ways that the cloud team works directly with trainings and upskilling. I'd highly recommend some of those from Google Cloud because they're leaning in pretty hard to make sure that the whole IT community has the skills and knowledge to not only make their work better, but also to help us. It's a nice virtuous cycle. And we're really proud that most big startups are actually on Google Cloud. So it's a really important resource. And sometimes there are ways that cloud can provide credits, for example, to get people rolling. Some of the programs we have that people can apply for, like Google for Startups as an example, there's also a way that there's some mentorship involved. And sometimes me and my team are involved in that just to provide some steer and guidance for these new organizations. I will say that going back to what we talked about at the beginning, some of the bigger organizations in health around the world think about automating their existing processes with AI technology. It's the startups that are thinking about transformation. So I'm a big fan and I want them to, like, there's some groups that I don't know if I even call them necessarily startups yet, but they're definitely earlier innovators, like a group called UV based in Japan and one called Dr Lib based in France. They're doing a lot of thinking about this bridging between the patient and the doctor and that communication pathway in a different way than interoperability and PHR, but really making it more fluid so it's easier, especially for patients, but also for docs. So there's some exciting ways that I think people are kind of rethinking the encounter, the exchange, and the work that we do. So we'll drop a link in there from the website that people can look at and and get some navigation to get some work with us, if that makes sense.
Thank you. Thank you.
I'm old enough to remember when Google was a startup, so back in the late 1990s. And I remember the transition from those stages, from things like Ask Jeeves and Yahoo to Google, was transformative.
What's really interesting about being at Google right now, I've been here 5 years. So I was here when we were kind of, big, and then we moved into COVID, and then Gen AI changed everything. It is very much like the company is reflexing our own startup muscles, around agility and sort of test and learn and learning that rapid cycle iteration. Because this is such a cliche expression, but it's like we're renovating our house while we're also throwing our wedding in the house. We have search, but we're also remaking it on the surface. It's a very exciting time for us. And I think it's given us a lot more appreciation for startups and sort of, all the unknown, but all the excitement also.
Must be exciting. I mean, being $1 trillion startup must be very different to being a $100 startup, but it's a really exciting time. And it's interesting because we reflect over the 25 years of Google, the amazing things that have happened there. What does the next 25 years look like? How do we see going forward, in particular around health, but obviously health is part of a broader social domain. So how do we see the transformation go over the next quarter of a century? I'm not asking you to do much there.
Okay, I can't even think that far out in advance. I'm just going to be honest. However, I will say that for the last 35 years that I've been in medicine, we've had very similar challenges. And just about anywhere on the planet you go, these are the things you hear. It's too expensive. It's inaccessible. Workforce is exhausted, or there's not enough people. There's too much information. People are overloaded. And just that it's too mass. It's not customized enough for individuals, not personalized enough. Gen AI is so good at solving all of those areas and kind of rethinking it. So I think whether it's in the science space or in the care delivery space or even, the bigger public health financing space, we're going to, I think, find that we can do more with what we have in terms of the people in hand. And we're going to be able to keep people healthier, longer, healthier lives because we're going to be able to be with them. When I say we, I don't mean we Google, I mean the AI products of their choice will be along that health journey with them and navigating but more importantly, anticipating their needs and making the experience more personalized for the every person. And ideally, health becomes more of an afterthought for people. It's not a hard thing that you have to deal with. It becomes built into your life flow. And similarly for clinicians, I think we'll be bringing joy back to medicine because you're going to have a bot that is your best version of yourself practicing medicine and that team around you of that AI capability, but you're still going to also have the human team that you get to work with. So it's going to be this nice, more seamless mix, I think, of technology and humans working together to provide a more customized, anticipatory experience for people. And I genuinely believe it's going to lead to more health for everybody on the planet.
I love that. I think you've just given me the title of the episode when it goes to air, Bringing Joy Back to Medicine. Beautiful line. Karen, thank you so much for joining us today and fitting time in your incredibly busy global remit schedule to come and spend some time with us in the PulsePod studio. It's been great having you here. Thank you so much.
Well, thank you guys. It was a blast.
It was great. And I have to say, your energy is infectious. I often describe myself as a grumpy old doctor, but you've brought joy back to my medical life as well. So I appreciate it.
Well, that was our conversation with Dr. Google herself, Dr. Karen DeSalvo. And honestly, it's one of those interviews that really stays with you. What I really love about Karen's perspective is that even when she's talking about AI, data, systems at planetary scale, whatever the topic it is, it always comes back to what drives her and what is most valuable to her, which is people, patients, clinicians, communities, and how we bring more dignity, equity, and of course, joy back into healthcare. As digital health continues to move at extraordinary speed, this conversation, I think, is a really powerful reminder that technology on its own is never the answer. How we design it and who is included in that process from the beginning, what we choose to prioritize, that's what really matters. So thanks for spending your time with us on Pulse, and we will see you in the next episode. So until then... Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Mara for all her support. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. And of course, visit pulseit.news to catch up on the news from Australia, New Zealand, and Ireland. And you can send any feedback at any time to George and me via email at pulsepod@pulseit.news. We always love to hear from you. See you soon.